Hello, everyone. Thank you for attending today's webinar. We've just got a quick technical thing for everyone to know. For those of you who are watching, if you would like to be chatting amongst yourselves, there is a chat feature inside the webinar, so you guys can be having conversations about what we're having, what's going on. Also, if you have any questions that you would like to ask the panelist or the host, there is a Q&A feature. For most of you, is probably at the top of your screen. So if you'd like to ask the panelists while the webinar is going on, or for the Q&A session at the end, please go ahead and put your questions in the Q&A session. All right, and I would like to hand it over now to our host, Linda Howard. Linda?
Welcome to Profound Conversations. So first, I'm going to ask our attendees to listen to a quote from Margaret Whitley. Very great change starts from very small conversations held among people who care. Very great change starts from very small conversations held among people who care. Today we have with us two individuals who care and that are doing work in the community in their own way. And rather than me introduce them, I will ask that they tell their story and for them to share a personal story that comes to mind from their most recent experience that punctuates who they are, what they do, and why they do it. Andre.
Well, being first is like being poor. It's no great honor, but I will take it. Thank you. So I think that the thing that reflects back to me most immediately is that I live and work in a neighborhood that is one of the most historic Black neighborhoods in America, actually, Baltimore's West Side, and specifically on Druid Hill Avenue. And I am also a gardener. So one of the first things I ever do if I'm ever moving into a place is start working on the yard. So I have, I get to see some beauty, even in the midst of degraded neighborhoods. And one of the things that is constantly sort of underscored to me in taking care of the back alleys, the backyards that face another row of houses opposite me on another street, is how easy it is to understand how the vectors for disease, for these kinds of environmental damages and so on and so on could be fomented in an area that's practically a swampland back there. There are all kinds of weeds and overturned buckets, and people, if we clean a lot, people sweep through the alley in a couple of weeks in the middle of the night and push out all kinds of trash and garbage. And even though dumping illegally is a federal offense, by the way, because it could be toxic waste in that dump, they do it all the time. The second we clean it up, they do it again. And sometimes it feels very frustrating to have to do that over and over again. But I'm also remembering, I think, a grandparent asking me, well, whose pickle is that? Whatever it is that I was worried about. That if you care about that thing the most, then you just clean it up. It's like, just like I didn't take a shower one time and go, oh, I'm spectacularly clean, I never have to do this again. Places that are this trammeled on will get used very poorly because they don't recognize the value of it. So you have to see inherently the value in the environment and the people in that environment as being valuable. And valuable enough to do it again and again. Like, I will not quit until I catch them, until I catch the dumpers, until I catch the other folks doing that. I have to see and understand the intrinsic value of where I stand. And I'm lucky enough to have lived in the world where that has been affirmed for me. But that's basically who I am. I care because I was raised in an environment of caring. I'm the oldest of 10 kids, so I was always taking care of somebody, and I learned to enjoy it very early on. So essentially what I'm doing is an outgrowth of the environment I was lucky enough to grow up in, and I want other people to have an environment that has something a beauty in it, even though the circumstances may be quite dire. So, long story, long-winded answer, but that's why I do what I do.
Thank you. And Dr. G.
Perfect. Thank you, Ms. Linda Howard. And so going second is great because I get to see how Mr. Andre Robinson, how much time he took and so forth. But Ms. Linda Howard, you are spot on. I mean, our narrative of our own experience is going to shape how we as adults act and so forth. And I'm a physician and a scientist at Johns Hopkins. I'm an assistant professor. I'm a lung doctor in critical care. I'm a son of immigrants. So my Baltimore story is different, but it's my story. And I say this because it's one big story of Baltimore. I mean, that's what makes the city so magical. Traveling 2 miles, you're always with a diverse population. So the first name is long. I've had the pleasure of saying it every day, so I know how to do it. But Panagis, Galiatsatos, or Dr. G, as a lot of my patients affectionately call me. And so my story real quick is I always like to start off by saying, I know we all have very specific thoughts towards Johns Hopkins. For me, Johns Hopkins has rejected me 3 times. And the first time was when my mom went to go give birth. They said no, they were full. So she ended up going to Franklin Square, which took quite some time during the heavy winters of February. Now circling back, the way life should have it is I'm now a physician there. And I walked in as a young doctor, specifically out of Bayview's campus, and I wanted to be stationed there because that's the community I grew up in, Greektown, Highlandtown area. And I just became so frustrated in the field of medicine. And it's not medicine's fault, right? Medicine should never have been perceived to be synonymous with health. It plays a role, but health is so much more than just seeing a doctor and so forth. But nonetheless, I would see my own community members, my next door neighbors to my soccer coach, fall victim in a variety of healthcare gaps that, regardless of all the money spent on my medical education, I couldn't help them. And it was frustrating for me. I knew the science, I knew the patient. Then I realized there was something else behind this, and realizing that contextual level variable, that where you're geographically located will dictate so much of your outcomes from health to economics, crushed me. I know as adults, we always get that kind of realization that the fairy tales that we've been seeing as a child, to some extent, that lens is lost. To me, that's what health equity means. We're seeing it and we're realizing that the American dream is it's not achievable for a lot of people. So I've devoted my entire career to, yes, learning the science as best as possible, but can we try to close those gaps? And my story and my narrative, as I just said, is mine, but one of the great ways of doing it is exactly what what we're doing right now, bringing in diverse people in a collaborative way to hear everyone's story and to work together. So I like to always say that I work at Hopkins because here's an institution that a lot of people don't perceive in a great eye, and I was guilty of that at one point, but now I get to try to rewrite their story and try to bring those resources to the communities that need it. So I can't thank you all enough for allowing me to be on this Zoom stage, especially with Mr. Andre Robinson.
Dr. G, can you tell us a little bit about the calls that you've been doing with Johns Hopkins around the coronavirus?
Yep. So how did this start? So when the pandemic exploded, and the governor Hogan mandated this lockdown. At this moment, my division starts sending out a schedule, and one of my anxieties began of realizing we all have to go in and out, work with the patients. And anxiety as a critical care doctor wasn't just I want to go and help these patients, but at the same time, it's making sure I can stay protected and my staff. So there's an anxiety there, right? But then that Saturday morning, when I got the schedule, was heightened in a different direction. And I received a call from a community member. This was Mark Carter. He's a leader over at Sandtown, Winchester, specifically at a New Song Academy. And he called me, and I'm already kind of anxious about going to the COVID-19 units. And now he's taking me to a very different direction that I, at that moment, didn't even think about. And he goes, this is going to ravage minority populations like you wouldn't believe. From the conversations about mass testing and screening, people aren't historical. They're still thinking about from Tuskegee to Henrietta Lacks, this is not going to go over well. And then other things, if you're going to ask people to quarantine, they need a source of income. They need food. Like you can't, the populations, the most vulnerable ones are going to be hit hard. My heart sank because everything he's saying, of course, is true. And right now it's been reaffirmed. And what we could do, as small as it may seem, but Ms. Howard, I mean, gosh, the conversation you opened it now makes these calls seem more extraordinary than I ever thought they could be. But let's get the community leaders, those who have already the trust of a variety of populations, let's get them a streamlined source of up-to-date facts, objective facts, met with an interactive conversation to hear their successes and their struggles of managing COVID-19. We can't sit as an authority dictating this without hearing about what people are struggling to do in order to achieve it, right? Saying quarantining sounds very easy if you live in a mansion with tons of resources, but hard to do if you're on Ponca Street in Highlandtown and you live day to day by a check. So we did these calls specifically for that. Like we need to hear, not to say that a hospital has the solutions, but gosh darn it, we can definitely network. We can definitely connect people. Imam Hassan from Masjid Al-Hassad over in Northwest Baltimore, one of his first conversations with me was, how do we get the Syrian refugees food? Not that they can't work. We connected him with Meals on Wheels, and it's been one of the more promising outcomes that we've had. So yes, these phone calls were designed to get to community leaders twice a week to hear some updated facts, answering their questions about COVID-19, but also hearing from them what we can be doing. And on Friday specifically, we always allow these community leaders to share their struggles and their successes. More struggles than successes, but we're getting there. But for me, we needed to make sure there was an outlet for voices to be heard from the community, to be met in real time with healthcare professionals who are pulling the strings to some extent of what all of this means and what do we do going forward. And we can't have that disconnect. We can't have the authoritative top stay disconnected from the community who's over here doing the best that they can. We have to merge them together. So that was the genesis of those calls. And it's been one of the most promising things. I mean, listen to everyone talk about what they're doing. And I emphasize, if you've ever listened to the call, the way I open it is, as a critical care doctor, I'm not your front line. I'm your last line. You all in the community, if you, with every single person, get the resources they need to quarantine and isolate, they will save more lives than any doctor or nurse, right? We are your last line. The community, in my opinion, is your front line.
And I will tell you, MLPI, we've listened in on the calls, and they are incredible and a great service to the community. So thank you for doing that, because some of the questions that I've heard and the information that has been shared on those calls, with communities leaders being able to share things that they're doing, as well as being able to get some questions answered. So thank you very much for the work that you're doing on those calls twice a week. And
thank you, Ms. Howard.
Yes. Andre, have you had an opportunity, or did you know about the calls?
I did not know about those just until I got alerted to being on the show, and it's a great pleasure to be on the show with Dr. G. So I wasn't aware of those, but we generally have been sharing very broadly. It's an interesting kind of sort of transfer, a bit of a drum that's been happening, because in the places where most of the information, of course, is being disseminated, as this is, in a digital environment. And of course, I live and work in a neighborhood that has very little broadband, right? So the stuff that's coming down is passing enormous chunks of the community, and depending on which block you live on, my block is 50% empty, and many of the blocks around here are about 50 or 60% empty. So there's various levels of information that is being passed, from absolute bullshit to rumor to conspiracy theories, and then facts are lost in there somewhere. And as we live in an environment where disinformation and misinformation has been weaponized, then there are a lot of people trading in that depending on how much discernment they have. So it's right now a bit of a mess, and it's always kind of chaos in the beginning of a crisis. So that's to be expected. But I was already in a pandemic, right? I was already in a neighborhood that has been experiencing the troubling standard that demography is destiny, right? Is very, very true in Black and poor communities really throughout the world. And Baltimore is a very specific place to study the specific impact specifically on Black people, because so much was encoded in the law that says that thou shalt not help those people particularly. And then so this would be what my friend Dr. Melva Taylor, who does emergency medicine in New York, would say, the expected surprise, right? There's a petri dish that allows various viral and bacterial infections to smack down on the most marginalized populations. And so they stay at the ready to be victimized by it because they were already in a victimization. So that pandemic was already here. And it's only going to get worse before it gets better. But I still, at the standing that I have, feel that it will get better because now we have folks like Dr. G working inside of that particular institution, and many others like him. I'm sure if we gave him $10 million, he could hire 100 of his friends in an hour to come and actually right that ship. And all of us right now have this technology, at least at our disposal, if not accessible. It's not accessible in my neighborhood because the information is not able to disseminate. I loan my Wi-Fi to my neighbors, as we had that discussion before, and it only goes so far. There's a limit to how far I can distribute that information. And the normal thing we would do would be to gather and share information. So it's only on this platform that we're able to debate and discuss and divine and discern what's going on. So those old inequities are going to continue to be a place where this pandemic will spread and will come back again and again and again, because they were already damaged by all this historical, weight and nonsense that's been parked in these communities since these communities were even allowed to be over here in this neighborhood, right? There were severely racially restricted neighborhoods in Baltimore until quite recently. And in many ways, they still are. So that's the biggest challenge, is that, yes, the information is out there, but wading through to find the facts is much more difficult in an area that's already been victimized by the successive wave after wave after wave of disenfranchisement, at all. You can fill in as many of the things around that. They've been dissed over and over again for decades and decades intergenerationally. So, that damage was already baked in.
Now, I know some other cities have done a pretty good job on getting the data and tracking who's been impacted most by the coronavirus. Howard, Dr. G, do you know whether or not that's being done in Baltimore? Like, can we definitively say the percent, how it's impacting African-American communities or more of the poorer neighborhoods?
Yeah, no. So as of last Thursday, so a week ago today, the state of Maryland released the demographics based on race. And then I think today, if not yesterday, they released it also based off ethnicity. And I say this because those numbers are needed. They're important. They begin to paint a very specific conversation that we need to have, which we're having today. And unsurprisingly, right, what we saw last week, African Americans, unfortunately, are making up almost the majority of the deaths that we're seeing from COVID-19 in the state of Maryland. The locations that are being ravaged by mortality, predominantly minorities. And the same thing in our Hispanic Latino populations. Last week, I was the critical care doctor in the COVID-19 ICU at Bayview. Half the population was nursing home residents from very disadvantaged neighborhoods or young Hispanic Latino men who need to work, who live with 8 others in their household, so the household density is high. And all of them said to me, you know what, everyone else in my home is sick. Should I be telling them to be worried? I'm sitting here, had to put a breathing tube in, and I'm like, you got to make this, you will make this call. Someone's got to make this call. And that story, that person, I'm assuming, can easily be copy and pasted to every other individual living in a socioeconomic status that is one of disadvantagement, that we need to recognize they need more resources. We need to allocate as much as we can. I mean, I apologize for how I sound, but to live in a country like this, and we all know the disparities exist, and now the pandemic is going to cause so many lives to be lost that could have been prevented if we took so much appropriate, not just around COVID-19 and getting more testing done early, but we're letting a pandemic showcase us everything that you and I have known, everything that Mr. Robinson discussed. I mean, a lot of lives will be lost because a strong enough commitment wasn't there to begin with.
Now, we've always talked about some of the health disparities and those social determinants of health that has impacted our community for decades. Now that we have the coronavirus issue, what are some of those disparities that, and either one of you can answer this question, what are some of those disparities that you're seeing that's having the greatest impact on the coronavirus affecting these communities more?
Well, I don't mind diving in on that because, again, I think that part of the issue is that we have the perfect condition for all the viruses, any of them that you named. This one in particular is impacted by something that's also the known known. It is synonymous that when you say the Black community, you mean the poor community, one of the poorest communities. Immigrant communities are also expected to be poor, but not always as poor as we remain. And there's, I think, still confusion about why that is. Why is it synonymous? Why is the community synonymous with a poor Black community? So that's one question we need to ask. Because when you start to pull at that thread, you'll see that those communities were ensconced in a kind of lucite, right, of poverty. They were to remain poor because of the lack of services, the lack of this, the preponderance of the trade in cigarettes and liquor and drugs and all the rest of that for generations. This is not a new thing, right? So as you actually pack all of that into an environment and it produces a very poor crop, you wouldn't be surprised by that, right? You wouldn't be surprised that ground that you never fertilized or watered or broke it up or did anything to would produce a poor product. So if in fact we are in these neighborhoods, not always by choice, and buffeted by all the social determinants of health, they are also the same ones of wealth. It doesn't matter how wealthy you are, you can see that right now. You can be as rich as you want to be, and if your lungs are collapsing, all of your resources, so for the most part, are going to go towards saving your life. But we have systems that are set up to advantage one group over another. So knowing all that doesn't make any difference if in fact you don't deal with the basic environmental degradation that most people of color, Black people particularly, poor people will eat poorly, not get to the doctor as often, won't take care of their teeth, they won't be adequately housed, they won't be adequately fed. And so the house itself is providing this enormous vector for all these things to buffet these folks. The challenge to all of that is that, as I said, half my neighborhood is empty. When we were finding the money to start to renovate and develop the houses, I could move all the poor people out of the squalor that they live in with enough subsidy and move them into the new stuff and open up half the neighborhood for a market to live by, because these people are no longer suffering in that squalor if they can get their health and their training and education and their economic viability. You see what I'm saying? There's every time you touch one thing, it opens up this other thing where they've been very purposefully buffeted by a thing. And we can't do anything about that until we have a moment that says an injury to them is an injury to the whole city. If 40% of the city falls off the cliff into squalor and degradation and death and disease and destruction, it doesn't matter how much of your barbecue you're planning to have in Canton, that's going to affect you. Bayview's not far behind. So that's really the challenge, is in this moment for all of us to realize, oh, wow, we really are, quote unquote, all in this together, because the death toll is going to be an optic that we're not going to be able to tiptoe around.
So now you're talking a lot about the socioeconomic, some of the socioeconomic determinants.
And the environmental
Right.
determinants, really.
Right.
Yeah.
And I'll ask Dr. G, is there any of on the physical health side, some of the things that you're seeing that is impacting the higher rates of contracting COVID-19 and the deaths resulting from it?
Yeah, I think Mr. Robinson laid out incredibly well how we arise to a lot of these healthcare gaps.
Right.
And a lot of it has to do with those contextual level variables of neighborhood status and the access you have in your neighborhoods. From a medical standpoint, this conversation, and I call it almost the physiology of poverty, because living in disadvantaged neighborhoods, where that contextual level, all of them, it's the access to certain foods that are processed that lead to your diabetes and hypertension, right? And so we realize those two pre-existing conditions, patients who have them and they get COVID-19, they have worse outcomes. Tobacco, right? So we know smoking injures your lungs. Guess what? If you get an infection, your lungs are going to do worse. We've seen already signs of that coming out of Wuhan, China, but also kind of preliminary results out of Italy. But I say this because guess where the majority of tobacco, of stores that sell tobacco, so the variable is called tobacco store density, goes hand in hand with more disadvantaged neighborhoods have higher access to tobacco. So a lot of the medical conversations that we have, they surface as a condition, right? Diabetes, high blood pressure, tobacco dependence, but they're rooted in these non-biological factors, right? The way the neighborhood is set up, the way the food access is set up, living in a constant stress, and you can overlay those communities with the highest homicide rates and the amount of stress they have. Yes, guess what? That is going to lead to hard to control blood pressure if you're living every day with this, how am I going to live today, and so forth. And I say this because that's what's escalating a lot of these patients once they get COVID-19. So the factor of, will they do worse if they get it? Yes, those pre-existing conditions will lead to worse outcomes. But then why are so many hotspots so vulnerable? It actually goes back to what Mr. Robinson was saying. The neighborhoods of socioeconomic disadvantagement have higher, what's called household density, meaning just more people live in a smaller compact place. So when you're asking them to quarantine and self-isolate, that's hard, right? And regardless of how the housing unit was set up, I say this because one of the examples that I always love to give is, Miss Beth, the leader of House of Ruth, which is a housing unit meant for women of violence and trauma. And their whole model of the housing unit is built on collegiality and sharing a common space and so forth. And, suddenly now this practice social distancing, how do they do that when that's going to unravel the mental health of them? So overall, there's non-biological factors at play that are much more prevalent in disadvantaged neighborhoods and in minorities that culminate in biological diseases that we call these morbidities and pre-existing conditions. And then you add a virus like COVID-19, it's, the match that we needed.
Yeah. Right.
I'm going to do a little shift, because we've been talking about some of the environmental factors that have led to it, some of the social economics and some of the pre-existing health conditions. And if on our flyer that went out, the subtitle was, "Are we truly essential?" And we've now been designated as essential workers, meaning going to work in the fast food restaurants, going to work in the supermarkets, going to work in places where there may be a much higher exposure. It may be driving an Uber, but you have situations where we have a population that is going to work, being designated as essential workers. And I won't say that this is my quote. I heard this, or this question, but I heard this on one of the news shows. And I don't remember who said it, but his comment was, are we truly essential workers, or are we sacrificial workers? And when you look at some of the conditions that those who are going to work because they have to, some of the conditions that they have to go into, where there's all the conversations about medical staff not having, protective gear. But what is the responsibility of the businesses like the supermarkets and the fast food restaurants to protect, quote, these essential workers so that they don't become the sacrificial workers? And Dr. G, I heard you say that your patient said something about him going to work because he had to, and then everyone in his household is sick.
I mean, at that point, the clinical experience that I have, reaffirms what you just said. To me, it's so ironic that the essential personnel are also those who look at the economic gap between those who are paid as non-essential employees, right? Look at how much of an income they get versus the essential. Yeah, by all means. I think that point is well taken.
Someone's joining the conversation.
This is all the work from home.
But
Exactly.
somebody came in for a consultation with Dr. G. Yeah, I think that, again, these things should be considered expected to a certain extent. Unless you want to have a 17-hour, podcast here, the bottom line is that this is always kind of been this way, right? The elites exploit those that are at the other end of the food chain because they're expendable and not so much essential, but they're expendable employees because I can always replace you because there's so many people that absolutely have to have a minimum wage entry-level job at all times. So we're using these euphemisms like essential worker, where in fact, once this particular crisis will end at some point or another, we'll go back to some semblance of the normal pandemics that we will expect in places where the generations that preceded us had to fight for dignity on the job of any kind, right? Because if you worked in a steel plant, you could be ground up by the machine. If you worked in a chicken processing plant, you could be ground up by the machine. You can get diseases at any workplace if they don't really give a shit about the workers because they're replaceable, they're expendable. So I think this is, once again, the old adage is to not let a crisis go to waste. Well, this is one that we also should really, really consider, that this will keep happening over and over again, that in fact, Baltimore may never get well completely. Hold on a second, I gotta plug up. Can you still hear me okay?
Yes.
Yep.
I need some more power, I need power. That Baltimore will never really truly be okay if it doesn't actually take this moment to look at how do we build a world so that that young voice that just came in the room with Dr. G, that they're okay, because we're really doing things right now for them. And if we don't do that for them in a broader sense of them, that there are many communities in the Black Butterfly that weren't able to quarantine at home or go to school at home because there's no Wi-Fi there, there's no computers there, there's no technology platform to enable them to continue to work. The economy is not online. The economy is making and moving stuff, right? That's the real thing that we quote unquote quote have discovered suddenly, that we were fought about paying them $15 an hour 3 years from now, when it will only still be worth $9 or less then. When in fact, we always knew that the lion's share of the economy was in small business and people making and doing stuff and moving it along. So where do we get that level of enlightenment from this bottom-up approach that COVID is going to provide us with, to say, hey, this can wipe us all out. There is no wall that you can't shut down. You can't be on this section of the plane. You can't only touch, because everybody that brings you stuff touches everything, including your food. So is this not the moment where we go, well, if I have an 8,000 square foot house, I can quarantine. If there are 9 people living in my 2,000 square foot house or 1,500 square foot house, that's going to be a little bit more difficult. So how do we get that population to have more resilience in their own systems? They can't be ensconced permanently in poverty. They just cannot. And if we look at the real reasons why that is, it's going to make a lot of people who are still with us very uncomfortable, and we have to be okay with that, because it's not okay for them to be comfortable with that level of oppression and suppression.
Now, do we know if anybody is having the conversations with these businesses about?
I think they are. I see a lot of it online. I'm involved in some of those. There's an organization here called, only because I'm trying to think of it, of course it'll fly out of my head for a second, but yeah, there are organizations here that are starting to kind of take that on, because they had a similar kind of culture going on in their own environment. And so when you start to address those things in your own environment, you don't have to look long to see the disparity in Baltimore. As Dr. G was saying, it's less than a mile from any one of us, up or down. So when we can see it so starkly in front of us and know that really we can't be okay with it being that way anymore, then I think that it's at least a moment. It's an opportunity in that moment to say, listen, we've got to build stronger connections. We've got to make sure that most of our kids who can get through, that we look at learning as it separates from education, because learning is supposed to happen very early on, and that's not happening in communities that are where our children are huddling in classes in their overcoats. They're not even thinking about everybody in the class doesn't have a laptop. They don't even have heat or water in the school, right? So Shift Ventures is the name of the company that I was thinking about. Todd Marks, there's a bunch of folks in this town at institutions too. City Lab, Dr. Thompson at City Lab, there are a lot of people who are tackling this stuff. And a lot of the wisdom in that room, and also in rooms like at the, Coppin Heights Community Development Corporation, there's a bunch of folks that are tackling this stuff. We're not privy to all of it because we can't gather 200 people in a room. But maybe this is going to be the big blessing of having 100 20-person conversations happening right now. There's dynamic stuff going on in Baltimore because we have such a robust intellectual knowledge and practice commons in the city. Yeah, Doug.
Mr. Andre, I want to piggyback on that, because you're right. I do really think that COVID-19 could be the trigger to fully address healthcare disparities. But caution I want, and everyone here can probably emphasize this. The caution I want to present is that in moments like this, even back to the riots 4 years ago, right? We had a lot of action, but in my opinion, not a lot of commitment. Commitment for the long haul, right? That's what you do your wedding vows for. It's forever. Action means, hey, in this moment where things look bad, let's do something. That's what hopefully this call can be used for, to put people to commit, not just act on the now and let's get some food now. No, we need a commitment. That's to me the biggest gap of all of this. Every time, whenever the next pandemic comes and we have the healthcare disparities that we're going to be faced with again, because if we haven't committed, we're right back where we were. I mean, we were just with riots 4 years ago. How much B1 Baltimore, how many things that we see? This was, in my opinion, if you want to conquer healthcare disparities, you need one asset that many of us all have, whether you're a son of an immigrant or minorities live in Baltimore. And that's grit and tenacity. We have it, right? That allows us to be persistent. Right? We need that to translate to others to make a commitment. That's what we need. Love this action now. Good. Makes a lot of feel-good stories. That's fantastic. But when the pandemic is over, and it'll end, COVID-19 will leave, if healthcare disparities still stay,
let me ask you, Dr. G, because we talked a little bit about your calls twice a week, but you work with Medicine for Greater Good. And I know with Medicine for Greater Good, you've worked on a lot of great initiatives in the community, reaching out to religious communities, doing education in order to impact some of the chronic conditions and screenings. Has COVID-19 changed anything that you're doing, or is there something different, new initiatives that we can expect to see as a result of COVID-19 or some of the lessons learned with COVID-19?
So it goes back to this conversation about action and commitment. When COVID-19 occurred, what was interesting, so Medicine for the Greater Good gives me honor and hope every day, because we get to make an impact not only in the communities, but on the 21st century physicians. That's the other goal. I want to put out as many disciples of this as possible so they go out knowing the science, knowing the patient, but knowing the community, right? That's the transformative thing we're trying to do. And then the pandemic hits, we begin these calls, and from the highest authorities of Hopkins, when people were like, how do we get to the community? Everyone's kind of working in their silos. We're sitting here, we're like, myself, Dr. Dane Hale as well, another colleague, and Selwyn Ray, another colleague, we're doing these calls twice a week. We get these amazing community leaders that are going to be saving more lives than ever we could. And I'm sitting here because all we did was pull on the strings of trust that we have built over time and time again. Those strings of trust were built, the fabric there, because as Reverend King out of Pullman said to me once, he's like, someone asked me, he's like, why do you trust them? He's like, they show up. That's half the battle. Just be present, be in their shoes, walk in their blocks, be with human beings. That's it. And so what I'm hoping changes out of this is that hospitals who have a community relations group or feel-good group that does a health fair once a year changes their tune. No, because if we ever face a new pandemic again and you need people to quarantine again, if you build an outstanding community group, a real one, not one that puts on a health fair once a year. Health fairs are fine. Don't get me wrong. I can always use new free pens, but a real commitment, one not just of a temporary action, one that every week we're touching base with you. Every month we bring you to our home, or every month we go out to your home. That's what I'm hoping changes. The 21st century hospital needs to be not on the sidelines anymore of these communities, needs to be in there. Not just geographically dropped in there. No, go in there. Know them. Know these human beings that are, give us identities. I mean, I'm a doctor because I have patients, but at the end of the day, I'd rather be seen as a community member that just happens to be a doctor.
Now, I know
changes.
I know some of our attendees are not from Baltimore. Can you just give people a sense in terms of where Johns Hopkins is situated in terms of in Baltimore and what communities it's in?
So there's two Hopkins hospitals, because if I don't talk about the other one, then I'm letting the one that I think is also equally important. So Hopkins Hospital, the behemoth, the kind of mothership of the entire Hopkins healthcare system, is located somewhat on the east side of Baltimore City and in a predominantly African-American neighborhood, and one of a median income, I think no more than $15,000. And Hopkins Bayview, located in the far east of Baltimore City, but still within the city boundaries, located in a really socioeconomically disadvantaged neighborhood, one really ripe with a lot of immigrants. So used to be Germans, then Greeks, now high influx of Hispanic Latino, as well as Northern Africans. And a lot of just blue collar workers who were ravaged when the factories left. Right. So both hospitals sit with high populations of minorities and high populations of socioeconomically disadvantaged individuals. That's where these two behemoths of a hospital are situated.
Okay. And Andre, I know you live and work in Baltimore. Can you give those on the call just a sense in terms of where you are? Because I want people to get a sense of where you are in the community.
Yeah, I'm sort of ensconced in sort of the beginning of the West Side, which really starts at sort of Charles Street. I'm on Druid Hill Avenue in the heart of Marble Hill. And it's really sort of the middle of the beginning of the West Side, if you will, but it's one of Baltimore's most historic Black neighborhoods. So I operate in between Dolphin Street and Druid Hill Park, which is also, actually a neighborhood that was built for the wealthiest Baltimoreans, if you really must know. It became a Black neighborhood over time after successive waves of white flight. Because there were covenants against Blacks or Jews living in this neighborhood when they were created, but they became eventually Jewish immigrant, and they allowed us in. And so then in the civil rights era, when the fair housing legislation kind of opened up and people could move to other places because there were very racially restricted neighborhoods all over Baltimore. So they're very well built and designed, very beautifully elegant architectural gems like all over the place that were abandoned and then became Black. And then of course once they became Black, you couldn't borrow any money from the bank to repair your house, so they sort of slid over 70 years into a very slow decline. So once other epidemics, crack epidemics, corrupt policing epidemics, crime epidemics happen, you continue to just devastate the neighborhood. So, but it is still the bone structure of one of the most elegant neighborhoods really on the East Coast is really still here. So I'm here because I'm a real estate developer and a community developer, a creative placemaker. I build galleries and theaters and restaurants and give people a place to play. Once these neighborhoods return, and I say once they return because they're quite beautiful, and every place around us, remember, is already completely gentrified, right? I grew up in Washington, D.C. Houses we sold there for $100,000 are selling for $900,000 now. So those folks will come to Baltimore because you can still find a house for $50,000 or $60,000. You may have to put $200,000 in to fix it, but it is well worth it because they are gems. So that's part of the upside, if you will. To a hammer, of course, everything looks like a nail. So I'm a builder, and so this is an opportunity to build and get things cleaned up. But once you do that and adequately house people, we don't have to make a killing on every house. You know, we can take a haircut on houses, and you can do them at this level of scale. And those people are adequately housed. I think you'll see all the other outcomes, both in education and health and social mobility more than anything else, which is the real answer to unbridled racism, is upward mobility. I think you'll see Baltimore become the center of the at least the multicultural world, because a lot of people are here from other places.
Excellent. I want to give Dr. G a moment to talk about the building healthy communities through medical religious partnerships. And I know this is what, the third edition of the book?
Yeah, it's our third edition, yes. Right, so I think a book about, kind of what I felt like was an obvious idea, right? Going out, talking to people and hearing how they can make their communities healthier. I mean, working with faith-based organizations, I'm a member of a church. I love my community. Adults gather once a week. Everyone is invested in one another. I mean, that is a great sense of a community. Mm-hmm. And knowing there's a cultural identity, everyone is looking out for each other. Well, why not have them hold some of the responsibility to help their loved ones stay healthy? And I say that not to shift responsibility off of a doctor or nurse, but I say this because every individual realizes the more they're part of a network, a cohesiveness and identity, they're going to have better outcomes. And working with faith-based organizations just made sense. And I remember the first time I worked with a congregation where the reverend, when he realized, this is Reverend Dred Scott out of St. Matthew's in Turner Station, when he realized, like, I think it was an idea he always knew, but he's like, I can be saving lives. I'm like, yeah, oh my gosh, if doctors and nurses, we see patients for 30 minutes every 3 months. I mean, I am not managing their care. They're managing their care. If they can have you all in the community help reaffirm these strategies, that's powerful. But more than anything, can we do it in a way that's culturally sensitive, is in alignment with what your faith and your beliefs are? Can we just be human beings that try to take a public health concern and meet it with a community health interests? One of my favorite examples this was with Reverend Dante Hickman, or I believe now he's Bishop Hickman, out of Southern Baptist. When we sat down with them, and our mind, we know the data, how low flu vaccinations are in African American communities. And so his discussion with us really was centered on economics. Like, we need jobs, right? We need jobs. My staff and I, right, from MGG, Medicine for the Greater Good, we come back about a week later, like, hey, can we come back? I know it's in short notice. And we said, hey, flu vaccinations have been proven to keep kids from missing school. And that's huge, because if a kid doesn't miss a day of school for being ill, that means the parent can go to work.
Yeah.
Guess what? Flu vaccine has been shown to help adults also not miss days of work. So if you don't miss a day of work, you didn't miss a paycheck. So here we took a community health interest, because working is a health interest. I mean, that gets you so much access. And we aligned it with a population health strategy of vaccination, and we got a bigger impact, right? We made a public health impact. And that came because we learned who the community is, and they learned us. We built a trust. There it is. So the book is that. It is having the communities out there, faith-based organizations, churches, mosques, synagogues, work with their hospitals to teach the hospital, you want us to worry about diabetes? Great. How do we do that where it's in alignment with how we preach, with how we work and so forth? And gives them the resources, the communities the resources to work with the hospitals, and then how to get it in an impactful way out into their community members. That's it. And I say this because it sounds like the world's simplest idea. Did it need a third edition? Maybe not, but Ms. Linda Howard, I'm still in all of that opening speech you had, that opening comment. Conversations can have the biggest impact. And that's what this book is. It's just identifies, hey, being able to be a human, interact with another human group, to be able to provide their resources out in the community. Yeah, that's life-changing. That's monumental. I will say the bias I have with the book is that the majority of examples come out of Baltimore. And I know, Ms. Linda Howard, you just said a lot of people on this call may not be from Baltimore.
Right.
But I think I can speak as well as Andre Robinson that the best thing that this city has to offer is its people. And I don't mean that being a son of Baltimore. I know I'm throwing myself in that, but it is, the grit and tenacity faced by, not faced, but that the communities have, and their diverse communities, I applaud them. how many people continue to keep their heads up when, they may be perceiving, especially in a time like this, that they're sacrificial. So I agree with Mr. Robinson, and the book, thank you for letting me speak on it, but it goes back to align with everything we've been talking about. If we can restructure the social engineering, and I know that's tough, but with a really devoted commitment with economics and transportation and mobility, I'm hoping my book never exists again because we've solved it. We fixed it all. I would love to be forgotten as opposed to a kind of a novelty right now. That's not fair. There's lives lost because of these disparities.
I'm going to challenge both of you to answer this question and to answer it in a very short time frame, because I want to be able to ask people if they have any questions.
Yeah.
But because we have people who are on the call that are from different places, and right now we're, around the country, really around the globe, we are struggling with this epidemic, and not just the epidemic, but the realities that the epidemic have brought forward. And so if you were to give other communities, because we've been doing a deeper dive in terms of Baltimore, in the next couple of weeks, we're going to be taking this same type of issues and looking at it across the country. But if you were to had to give some other communities or institution one piece of advice as to how they can be proactive and what can we do kind of moving forward, looking forward to change, to get a better outcome than what we've had so far with the coronavirus. So I know I said a lot, and I'm asking you to answer it in a short period of time.
Mr. Robinson, do you want me to go first since you went first?
Yeah, go ahead. Yeah.
So in brief, actually, you gave my examples. Maybe this is an easy cop out for me, but it's those calls, what they represent is two groups working together and talking in a mutual moment. So I know, again, it sounds simple, but just create a connectivity with doctors, scientists, working with the community, even if it's 2 hours a week. That's 2 huge hours. That's massive. And make it interactive, not just let's talk and people will listen. No, make it interactive. Let them email you questions and talk about it. That's my simple request. You know what? If you want to hear what's happening with the community and why they're struggling to quarantine and isolate, well then listen to them.
Thank you. Andre.
No, I agree. If I would offer any advice to any other community that's wrestling with this, I would actually encourage them to sort of dial it back to, Gregory Porter has this wonderful song called Take Me to the Alley. I don't know if you've ever heard it, but if you don't go to the alleys, if you don't go to the places where people are the most suppressed and think that the glossiness over here at some high level think tank conversation is going to actually trickle down to those people where the disease the diseases of society, right? The original corruption of racism has seeded this thing into the ground. And if you don't go to those places and try to deal with that, and I know it's a tough thing to address, makes people very uncomfortable, living it is exponentially more uncomfortable. So if you don't go to those places where the damage has most been done, well, any surgeon can tell you, you can't just go, oh, that looks pretty ugly, just to stitch it up and make a nice clean dressing over top of it. That thing will continue to corrupt internally and degrade until that organism is dead. So you've got to go to those places and get those other things sort of cleaned up, face the facts. As Baldwin says, you can't solve anything that you cannot face. You face it and then get some friends to deal with some stuff. So we just, under Neighborhood Builders Incorporated, got a group of other developers who are already working in this community, many of which were friends and colleagues anyway, and said, hey, we've got to worry about food and housing. Education, we'll handle that because everybody's going to have to repeat this year. I don't care what anybody thinks, right? This year is done. You're going to have to repeat this year academically. But if you can deal with housing and food, there's a lot of stuff you can invest in, still make manifest inside of healthy neighborhoods you are rebuilding that are clean. You clean the wound and then you stitch it up. You don't do the reverse of that. So that's what I would advise, is people to get into the place where the ugliness is, face that, and bring some friends with you. Many hands make light work.
Wow, thank you. I'm gonna, so those of you who are our attendees, if you could start to just think about the questions that you may have. If you can do a raise the hand, if you wanna type it in the comment box or the question box, you can do that. But before we get to the questions, and I hope that Dr. G and Andre can hang on with us for a few extra minutes. Is that okay, in case we have some questions? Great. But I do want to, before people drop off the call, if anyone has to drop off at the top of the hour, I just want to do a couple of acknowledgements. And one is that we want to thank Muslim Life Planning Institute. We want to thank Medicine for Greater Good and Johns Hopkins Bayview Medical Center for all of the work that they do, and for Dr. G being with us, and also Andre for all of the work that he does. And Andre has been, this is his second time being a guest on our show. So we are very grateful that you continue to support our initiatives. And we are greatly appreciative to all of the volunteers and the MLPI team that makes this happen. And that's my business partners, Samuel Sharif and Kareem Ali. They're both my business partners and my brothers, and two very incredible men that are with us with Muslim Life Planning Institute. And also Erica Christie, who is our engineer, and she works very diligently behind the scenes and working with people before they get on the line to make sure we have all of the technical issues hammered out. So I'm going to turn it over to Erica to manage the questions. And I already see that there's one hand up. So Erica, I'm going to turn it over to you.
And the audio is open for our person who had their hand up. All right, are you there?
Yes, I am.
Yes, please, what is your question?
This is Brother Hakeem in Kansas City. And my question is, how do we get people, minorities in particular, to become less stiff-necked with the guidelines that are in place that is actually bringing about the death toll to the communities that are impacted the most?
Brother Hakeem, when you say stiff-necked, explain that a little bit more.
They aren't taking any precautions here in Kansas City. Okay,
got it. Yeah. I see very much the same thing happening here in Baltimore in the communities that I live in. Young people are still gathering because they generally have no place else to go. They're still on the corner washing windows because, of course, they used to be fed at school when they were in school. And so I think that is part of the challenge, is that, and I was talking with some colleagues earlier, Brother Elijah and Ezekiel Kelly earlier, about this, and that I think that the bottom line is that there's only a small percentage of the people in the beginning that are ever going to get it, and then you model better behavior. People sometimes have to see it in order to believe it, So if in fact you have a difficulty, there may be more difficulty in following quote unquote good advice than you may think. If in fact your house is overcrowded, quarantining is not an option. If in fact you're inadequately fed, then you're going to go out to the corner store. As a matter of fact, I have people that go to corner stores 4 or 5 times a day because there's no, it's hard to carry 4 bags of groceries home from a market that's a mile away. So there are conditions that are already visited in a lot of these neighborhoods where the stiff-neckedness, to use your term, is the most severe in places where people are disconnected to institutions of fact giving, right? Because we used to gather to do that. Now you have to trust this bombardment, which is filled with a cacophony of some of its disinformation, some of its rumor, some of its absolute nonsense. So it has the lack of penetration, I think, is because of the weakness in our basic structure. The main structure in the Black family is to gather, and that is now, quote unquote, soon to be against the law. So that's going to be part of the challenge. I think you're going to see a sea change for a little while until people realize, oh, I came home like in Chicago. I went to the funeral and came home and killed grandma. And then people will go, oh, I guess I should stop doing that. I stopped very smart members of my own family from having a party, masks and flasks party with children very early on in the crisis because they weren't paying attention. These people are degreed, but their object, the rumor was, well, it doesn't really affect Black people that much, so we're not getting it, or it only affects old people, so we're not getting it. And then the information came out. So I think you have to be patient a little bit and model for anyone who has ears to hear, and then let that spread, let that be viral.
I'm going to reaffirm, Ms. Robbins, what you said incredibly well. I mean, if you think about the calls that Ms. Howard was discussing for us, we get the community leaders on those. Trust, they're the ones that a variety of populations will listen to. If I go in as a doctor to a community that doesn't really know me, what are they going to, who am I to tell them what to begin to do? I mean, again, this is really difficult, right? The social reengineering requests doesn't happen overnight, but if it can come from a trusted voice, coming from a government or an academic hospital, those have soured relationships a lot of times with communities. I recognize that. And so us then coming back, suddenly paying attention to communities, they're like, well, what are you doing here? Now you want to talk to us? I get it. So
right.
Working with the community leaders, that's more powerful. That's who helps send that message. Identify those individuals and get him or her to kind of be the voice for the community. That will move. In my opinion, that's what I've seen to be the catalyst of all of this.
I think some of it also is intergenerational. You also have to make sure that the influencers are in the right generation, because young people don't listen to old people. I mean, did we when we were young people? So
no, very true, very true.
Younger folks as well are in the generation that actually you're trying to impact, and make sure the influencers are also in their demographic, because the trust factor is the biggest factor.
I saw this in the chat to the panelists that someone asked, can comments be made verbally? So if someone actually has a comment, you can also raise your hand for that as well.
And hello to everyone.
Yes.
My question is, where is the cost-benefit equation here? I'm not hearing people talk about it. And I think that's very dangerous. Where is the benefit? Where is I posit respectfully that the cost far outweigh the benefits that are being imposed on the economic, spiritual, and intellectual infrastructure of an already damaged society.
So if I may take a stab at it, and I know I'm going to come at this from a physician standpoint, so it's just the angle that I can have. The COVID-19 virus is diabolical in a variety of ways. That it's not the quantity that scares us, it's the quality that it has on each patient that comes to the hospital. If you have one COVID-19 patient enter your hospital, that patient needs what's called a negative pressure room. I can tell you a rural hospital has only 4 of those rooms in a hospital, right? So every 100 beds, 4 of them are designated for negative pressure rooms. All right, great. So that means that patient can go in there and be safe that he or she won't transmit that to others. Then you need the PPE. Your average nurse goes into a patient's room once every 45 minutes. That means he or she has to change out of those outfits. Your doctor may go the minimum once, maximum maybe a couple more times in and out. So all of that is requirement. And then they need whatever intervention that they'll usually need from COVID-19, oxygen, whether it's nasal cannula, or we start increasing it with CPAP and BiPAP, and then maybe ultimately mechanical ventilation too. The quality of care for a COVID-19 patient, and then the disease in of itself, we know the median stay, so not the average because it gets skewed, but a person, if you get this, especially if you develop symptoms enough to get in a hospital, you're looking at 21 days straight. If you get in an ICU, you're looking up to 40 days of staying in there.
Right.
And all of those resources I just told you, for one patient, sounds like a lot. If you get 100 of those, you're right, it's not gonna make a dip on the overall mortality, but it's going to exert all the resources of a hospital. The reason why Hopkins gets so many patients sent from elsewhere, because the hospitals, what they're doing in Frederick County and Cecil County is, they'll stabilize, they'll send out. So they can make a new bed for the next patient because they can't convert their hospital into an entire intensive care unit. Johns Hopkins Hospital has become one large intensive care unit. For all of this is because if you don't, what's going to happen to your doctors and your nurses is we're going to have to make the decision that no one wants to make. Who do we allocate these resources to, right? If we have enough negative pressure rooms, that patient's spreading the infection to everyone else, including the staff that are taking care of them. The reason why we have jumped on this, and my frustration is I know we're all, like Donald Trump, we're all about ratings and numbers. You need enough patients in a pandemic to freak us all out because your average hospital is not built to manage a pandemic. It is not. I just told you a negative pressure room, 4. That's it. You get 4 for every 100 in a rural community hospital. You get a dozen in one day, that means 8 of those patients are going to sit, not getting the proper care, and die because no one could allocate what they need. That's what bothers us. It's not the grandiose numbers. It's that we're about to be making decisions to say some of them aren't going to get the care and some of them will. That's what you're forcing healthcare to do in a time like this. No one wants to make that. And I don't want the lives of just 10,000 people be washed away because we were expecting 1 million people to die. That's not fair to those 10,000. So that's why we make such a big frustration. What we discuss is that probably close to 40% of the deaths worldwide were due because we couldn't get them the resources they need. That breaks my heart. Saving one life is a blessing. The fact that we let 40% die because we couldn't get them the healthcare. We have to live with that consciousness on our heads.
I don't know. I see one other hand up. I don't know if we got time for one quick or do Erica.
I have 2 hands up right now.
Hey, I'm here. Come on. Give me my phone number. We'll just kick it until.
Let's get at least one. If anyone needs to drop off, they can get the recording. If the person who has their hand up promises to make it brief.
Yes, Nair, go ahead.
Okay, great. Thank you. Hello to everyone. And I've gained quite a bit of insight. I really just have a question specifically for the doctor. I've heard a lot of responses that I was looking for, but in a solution-oriented culture, I understand that we always look to respond and look to, like the doctor said, find resource to avoid a situation, to grow, or avoid the growth or the worsening of a situation. My question is this: how did we get here with so much lead time? And the reason why I'm speaking to this is because I was about 30 days ahead living in China. I'm currently displaced because I'm in America now and I live in China. All of my things are in China. I'm here with a carry-on bag. I was 30 days ahead of this what they're calling this pandemic, this panic-demic. I was 30 days ahead of this, maybe more actually, because I think I left January the 12th for holiday travel with a carry-on. And I slowly saw this progress. I spent time in Thailand and heard a little bit more. I spent time in Japan, heard a little bit more. And eventually I decided to make the move to come back to America versus going back to my temporary home in China. How did we get here?
How did we get here, Dr. G?
Yeah, so I'm not going to touch on the health disparities component of how we got there, because that's decades and decades and decades. How we got here specifically, I can answer that incredibly briefly. In order to create the models that we need, we take 3 variables specifically into account, because what we're doing is trying to calculate what's called the reproduction rate of a virus. And 2 of them is this, how susceptible people are getting the infection. So that means, is it airborne, is it droplet, and so forth. And the other one is how infectious it is, meaning once we get it, symptoms. January 19th was America's first case, as well as South Korea's. Look at South Korea. What they did immediately was do about 20,000 testing a day, right? And they have been flat with the curve ever since then. And that's amazing. From a doctor's standpoint, we love that. It means patients come in, they're sick, but at a nice steady pace where we can work. And going back to the first person's comment, allocate those resources in a much more efficient manner. We did not test.
Got it.
We don't test thousands a day. If you don't test, we can't get that one number that we need to make the most mathematical model, guess, estimate, hypothesis to govern policy. We didn't have that. And now we're at the mercy that every week you're like, oh my God, these doctors keep changing what they're saying. Yes, because we get new numbers, right? Our numerator is so much smaller than the denominator. Politics with that denominator. We don't want the numbers to grow. Well, you know what? If you don't, guess what? The other number that's going to grow is mortality. What we can do with the numbers is make what South Korea did, dedicated quarantine areas. It means some areas get to be more loose, others more strict until the virus wears off, then they're released. That's it. I'm not a politician. I'm a public health person to some extent, but that's the mass difference. Just look at those 2 countries go in 2 different directions when they had the same case the same day. Different time zones, I get it, but nonetheless.
So we are going to end today's session. We do have 2 more sessions the next week and the following week, the 23rd and the 30th, that will also be dealing with some of these public health concerns. So if you have registered for this event, you will get a notice of the upcoming Profound Conversations. Thank you for joining us.